Many people trust their neurosurgeon's recommendation implicitly, assuming it's the optimal choice. I also shared this belief until I began observing the outcomes more closely. Counting the patients who walked into my operating room for what their referring doctor called a routine brain procedure and faced significant changes in their quality of life, not necessarily improved, changed. A man who came to me for a tumor we had been watching for 3 years. His family pushed for surgery. He went in, sharp, alert, telling jokes in the prep room. He experienced a temporary loss of speech for 6 months. A woman who survived a major spinal cord operation but lost her independence entirely. She spent 2 years in a rehabilitation facility. She required extended care and was unable to return home. An important aspect that is not commonly discussed is that the older your brain is, the more challenging it can be to recover from the stress of an operation itself, distinct from the underlying disease. My name is Dr. Marcus Reeve. I'm a neurosurgeon with over 20 years in the operating room. I've opened skulls, repaired ruptured aneurysms, removed tumors from places most people can't pronounce. And today, I'm going to tell you the truth about 5 brain and neurological surgeries that carry serious hidden risks for people over 60. Let me ask you something. If you take a brand new computer and one that has been running hard for 30 years, and you put them both through the same upgrade, do you expect the same result? Of course not. Medical approaches for a 65-year-old brain have historically often mirrored those for a 40-year-old, using similar protocols and expectations. This approach is evolving, but perhaps not at the necessary pace. Here's what happens inside an older brain when it goes under general anesthesia. The neurons become temporarily disoriented. The brain's protective filtering system, the blood-brain barrier, becomes more permeable under anesthetic stress. The glymphatic system, the brain's overnight cleaning mechanism, gets disrupted. And something called post-operative cognitive dysfunction sets in, POCD. Temporary confusion, memory gaps, personality changes that can last weeks, months, or, in some cases, years. In patients over 70, POCD occurs in up to 30% of cases after major surgery. In patients over 80, some studies put that number at 40%. I want to be clear about something important. Age alone is not a reason to avoid surgery. I have operated on 80-year-olds who recovered faster than some of my 50-year-old patients. Age is a number. Brain reserve is not. Brain reserve is the neurological equivalent of physical frailty. It means the brain's ability to absorb stress and bounce back has dropped below a critical threshold. A brain that has spent decades managing well becomes far less tolerant of surgical trauma, general anesthesia, and prolonged immobility. And nobody is routinely testing for brain reserve before recommending surgery. That distinction is going to matter a great deal right now. Surgery number 1. Craniotomy for incidentally found meningiomas. A meningioma is a tumor that grows from the membranes surrounding the brain. They are among the most common brain tumors in adults over 60. And here's the critical fact most patients are never told. The vast majority of meningiomas never cause a single symptom. Ever. They're found on MRI scans done for something else entirely. A headache, a fall, a routine check. The radiologist mentions it. Suddenly, a patient who was completely fine 2 weeks ago is being referred to a neurosurgeon. And often, the recommendation is, to remove it. I want you to hear this clearly. In a younger patient with a growing symptomatic meningioma, surgery can be the right answer. I've performed that surgery. It saves lives. But for an older patient with a small, stable, asymptomatic meningioma, an elective craniotomy often presents risks that may outweigh the potential benefits. The surgery requires opening the skull, navigating delicate tissue, and managing bleeding in an environment where every millimeter matters. Complication rates in elderly patients include stroke, infection, significant cognitive decline, and seizure disorders that can be harder to control than the original tumor ever was. An alternative that merits more frequent discussion is active surveillance, watching the tumor with regular imaging. The majority of incidentally discovered meningiomas in patients over 65 never grow significantly. Many never change at all over 5 or even 10 years. Ask your neurosurgeon this question: what is the growth rate of my specific tumor? And what are the odds it causes symptoms in my lifetime if we don't operate? A good surgeon will give you a complete answer. That answer might be the most important piece of information you receive. Surgery number 2. Elective carotid endarterectomy in asymptomatic patients. Your carotid arteries are the main vessels supplying blood to your brain. When they narrow from plaque buildup, a surgeon can clean them out surgically. This procedure, carotid endarterectomy, is genuinely life-saving in patients who have already had a stroke or TIA caused by carotid disease. But here is where I see real harm being done. The procedure is increasingly being recommended to older patients who have carotid stenosis detected on imaging but have never had a single neurological symptom. Asymptomatic carotid stenosis. No stroke, no TIA, no weakness, no vision changes, no speech difficulty. Just a narrowing seen on ultrasound. The research on operating on these patients is genuinely divided. Studies show that in the current era of optimized medical therapy, meaning the right combination of blood pressure medications, statins, and antiplatelet drugs, the stroke risk from managed asymptomatic carotid disease is about 1% per year. The surgical risk in elderly patients with multiple health conditions can approach or exceed that number. You are operating to reduce a risk that medical management may already be controlling adequately. Before agreeing to carotid surgery for asymptomatic disease, ask your surgeon, compared to optimized medical management with my specific health profile, what is the absolute risk reduction this surgery provides? That question requires a real answer. And if you don't get one, get a second opinion. Surgery number 3. Complex cervical spine surgery for degenerative changes. Neck pain in your 60s and 70s is nearly universal. Arthritis, disc degeneration, bone spurs pressing on nerves. Almost everyone over 65 has some degree of cervical spine degeneration visible on imaging. And increasingly, the solution being offered is surgery. Sometimes aggressive surgery, multi-level fusions, hardware implanted through the front or back of the neck. Here is what the research actually shows. For patients who have clear neurological deficits, meaning true weakness in the arms or legs, loss of fine motor control, or progressive myelopathy where the spinal cord is being actively compressed, cervical surgery can be necessary and highly effective. But for chronic neck pain and discomfort in an elderly patient with degenerative changes on imaging, the picture is very different. Studies consistently show that for this population, outcomes from complex cervical fusion are not significantly better than structured physical therapy, targeted injections, and pain management. The outcomes are not necessarily improved, and the risks are considerably higher. The complications in elderly patients include hardware failure, adjacent segment disease, where the vertebrae above and below the fusion begin to break down, infection, and the same post-operative cognitive dysfunction I described earlier. General anesthesia for a multi-level cervical procedure in a 75-year-old with existing cognitive concerns is not a trivial event. Have you ever been told that surgery was your only option for neck pain? Write that in the comments.
I want to know how many of you have heard those exact words from a spine surgeon.
Surgery number 4. Deep brain stimulation for early-stage neurological disease. Deep brain stimulation, DBS, is one of the most remarkable technologies neurosurgery has produced. For patients with advanced Parkinson's disease who are no longer responding adequately to medication, it can genuinely transform quality of life. I have seen it work. I respect the procedure enormously. But DBS is increasingly being discussed for patients in earlier stages of disease. Patients who are still responding well to medication. Patients for whom the symptoms, while real and frustrating, are manageable without brain surgery. The procedure requires placing electrodes deep inside the brain through precisely drilled holes in the skull. In a well-selected younger patient, the surgical risk is acceptable relative to the benefit. In a patient over 75, with any degree of cerebral atrophy, cognitive vulnerability, or cardiovascular disease, the risk profile changes significantly. Hemorrhage at the electrode site, infection, worsening of cognitive symptoms, post-operative confusion severe enough to require extended hospitalization. I am not saying DBS is wrong for elderly patients. I am saying the conversation about timing matters enormously. If your current medications are managing your symptoms reasonably well, the question worth asking is, what specific function am I losing right now that surgery would restore? And what would recovery look like for someone with my exact health profile, not the average trial participant? Surgery number 5. Emergency craniotomy in elderly, frail patients. I need to stop here for a moment because this one is different from the others. You don't choose emergency brain surgery. It chooses you. A ruptured aneurysm, a subdural hematoma after a fall, sudden, severe bleeding in the brain. These situations don't wait for a calm conversation in a neurosurgeon's office. But here is why this belongs on this list. Knowing the risks in advance, before an emergency happens, changes how families make decisions in those terrifying moments. Emergency craniotomy in patients over 75 is associated with high rates of mortality and severe disability. Not because surgeons lack skill, because a vulnerable brain facing sudden trauma has a significantly challenging prognosis. The brain swells. The intracranial pressure rises. The surrounding tissue, already less resilient, begins to show the effects of surgical manipulation within hours. And the inflammatory cascade in an elderly body does not resolve cleanly or quickly. So what can you do with this information? 2 things. First, do not ignore warning symptoms. Sudden severe headache unlike any you've had before. Sudden weakness on one side. Sudden speech difficulty. Sudden vision changes. These symptoms demand emergency evaluation. Catching intracranial problems early sometimes means treating them before they become catastrophic. Second, have the conversation with your family now. Not in the hospital at midnight. Now. What are your wishes if emergency brain surgery is the only option? What quality of life matters to you? What does that mean to you personally? These conversations are not morbid. They are among the most loving things you can do for the people who will one day be standing in that corridor.
Now let's talk about what you actually do with this knowledge. Before any major brain or neurological surgery, there are 4 questions every patient over 60 should ask. Write these down. Question 1. What happens if I don't have this surgery? A good neurosurgeon will give you an honest answer. If the answer is that nothing urgent changes in the next 6 to 12 months, you have time. Time to think. Time to get a second opinion. Time to optimize your health. Question 2. Is there a less invasive alternative? Medicine has changed enormously. Radiosurgery, using precisely focused radiation beams, can treat certain brain tumors and vascular malformations without opening the skull. The right combination of medications can manage some conditions previously thought to require surgery. Options that didn't exist 15 years ago are available today. Question 3. What does recovery realistically look like for someone my age and my specific health profile? Not the average patient. You. Your brain reserve. Your current cognitive baseline. Your living situation. The answer should be specific, not generic. Question 4. What is your personal complication rate for this procedure in patients over 70? Neurosurgeons track this data. They know their outcomes. A confident, honest surgeon will tell you. If they seem uncomfortable with the question, that discomfort is information worth having. I want to tell you about a patient I'll call Raymond, 73 years old, retired engineer. His family physician found a small meningioma on a scan ordered after a minor fender bender. Raymond was completely asymptomatic. No headaches, no cognitive changes, no weakness, nothing. He was referred to a surgeon who recommended immediate removal. The tumor, he was told, could grow. It could become dangerous. Better to deal with it now. Raymond came to me for a second opinion. He was sharp, articulate, and clearly frightened. He had already told his wife to prepare for the worst. When I reviewed his imaging, his full health profile, and the tumor's characteristics, I sat down with him for 30 minutes, and I told him the truth. His tumor was small, showed no growth markers, and was located in a position that made watchful waiting medically appropriate. The odds of it causing symptoms in his lifetime were genuinely low. The risks of surgery for his specific brain were not trivial. He chose to monitor. That was 5 years ago. Last year, he sent me a note. The tumor had not grown a single measurable millimeter. He had spent those 5 years gardening, traveling, and reading. His words, not mine. Dr. Reeve, you gave me 5 years back. Here is what I need you to understand. This is the single most important thing I will say today. A surgical recommendation is not a verdict. It is the beginning of a conversation. You are not a passive recipient of medical decisions. You are an active participant in your own neurological care. The moment you sit across from a neurosurgeon, you have the right to ask every hard question, to request every alternative, and to take every day you need to think. The surgeon holds the drill. You hold the choice.
Let's bring it all together. 5 brain and neurological surgeries that carry serious hidden risks for people over 60. Craniotomy for incidentally found meningiomas, where watchful waiting is far more appropriate than most patients are told. Elective carotid endarterectomy in asymptomatic patients, where optimized medical management may provide equal protection. Complex cervical spine surgery for pain, where the evidence for meaningful long-term benefit is weaker than the recommendation rate suggests. Deep brain stimulation in early-stage disease, where timing and patient selection matter as much as the technology itself. And emergency craniotomy, where the best protection is recognizing warning symptoms early and having honest family conversations before the crisis arrives. None of this means avoid all brain surgery. Neurosurgery saves lives every single day. I have been part of that. I am proud of that. The message is this: be an informed patient. Ask the hard questions. Request the alternatives. Get a second opinion, and if necessary, a third. Your brain is the most complex structure in the known universe. It deserves a surgeon who explains everything, and a medical team that treats you as the intelligent adult you are. What question would you most want to ask your neurosurgeon before a major operation? Tell me in the comments. I read every single one. And if this video helped you or someone you care about think more clearly about a neurological decision, share it. That one share might be the most important thing you do today. Take care of yourselves. Stay curious. Keep advocating for your own brain. Everything shared in this video is general medical information based on published research and clinical experience. Every person's situation is unique. Before making any decision about surgery or treatment, please have a full, honest conversation with your own doctor or specialist.